Hello my dear students, hope you all are doing good. Today topic is diuretics. What are diuretics and why we are taking diuretics? Before knowing about this diuretics, we have to know about kidney and what is playing a major role in formation of urine. So I hope everyone knows how our kidney is working. So let's go into the basics. The basic first one is structure of kidney. You have a pair of kidneys on either side of your spine at back, okay? And it will be below your ribs and behind the belly. So if you see, this is kidney. Let's see the parts of the kidney. Your kidney is made up of two parts. One is cortex and medulla. And if you see this one, this is cortex. And if you go into this whole area is called as medulla, and these are called as pyramids. And this is renal artery and this is renal vein. So these are the parts. The outer layer is cortex. This is cortex, and when it comes to this outer layer, this is called as fibrous capsule. Okay, and if you see this area, this is medulla and these are pyramids. This is major calyx and this is minor calyx, and this is renal artery through which our nutrients and blood will be supplied to each and every part of the. Here I have kept till pyramids only, but it will go into cortex, and this is renal pelvis. This area is renal pelvis. So our kidney consists of thousands and thousands of nephrons. So where these nephrons are located, glomerulus and convoluted tubules will be here. For example, so from in cortex to, it will be like this to the pyramids. Okay, so our nephrons will be like this. If you see our PPT, so this is how our nephrons will look like. So if you go into deep, so if you see, this is the nephron. Each nephron consists of two parts. One is renal capsule, which is this area, okay, and the other one is renal tubule. The whole thing, remaining whole thing is renal tubule, okay. So one is renal capsule and the other one is renal tubule. So if you see, this is nephron, a simple diagram of nephron. So this is efferent arteriole and this is efferent arteriole. This is Bowman's capsule and this is network of capillaries. This is called as glomerulus. This glomerulus will be upon this Bowman's capsule, and this is proximal convoluted tubule, and this is loop of henle, and this is ascending loop of henle, and this is descending loop of henle, distal convoluted tubule and collecting duct. So what will happen here? Our blood will go like this. Okay, blood is going like this and it is getting filtered here. Okay, and it is coming here. Now come near to this filtrate. Here it will leave a filtrate. This filtrate will go into this capsule, and from here this will enter into proximal convoluted tubule, and proximal convoluted tubule to ascending loop of henle, and from ascending loop of henle it will go into descending loop of henle, and then from distal convoluted tubule, and from there it will go into collecting ducts. So this formation here, the filtrate, how it is forming, let's see. So this is how our only Bowman's capsule and glomerulus look like. So if you zoom into this glomerulus, you have three layers for this filtration of this urine. So what is urine? Urine is a liquid byproduct in which we will be excreting 91 to 96% of water along with inorganic salts and organic products like sodium, chloride, potassium and calcium, magnesium and some proteins, hormones. Normal human being whose kidneys are working properly, they will produce, if it is a female, they will filter 150 liters per day. And when it comes to male, they will be filtering 180 liters per day. In that 180 liters, it will filter all the blood constituents except the plasma proteins and lipids, and it won't filter our blood cells and platelets. It is filtering 180 liters of fluids every day, but are we releasing the whole filter it as a urine? No, actually, like as it is 180 liters, the remaining fluid is reabsorbed, but only 1.5 liters of urine is produced per one day. Okay, if it is filtering 180 liters, and the output will be only 1.5 liters, and remaining it is reabsorbed by our tubules. So our drugs, which are diuretics, they will be primarily inhibiting this tubular reabsorption. Okay, now I am talking that tubules will be reabsorbing this fluid, and we will get only 1 to 5 liters. But when this is inhibiting this tubular reabsorption, what will happen? The urine output will be more. Okay, even this tubular reabsorption is decreased for 1 or 2%, it will show a huge output. Okay, when we are talking about heart, we have given to the patients this diuretics, because in their body they will be having so much of fluid. To get rid of that fluid, we will be taking this diuretic. So when we are taking this diuretic, the whole fluids in our blood which we don't need, they will go out of. Okay, that is diuretics. So before going into deep discussion of this diuretics and what are the drugs in the diuretics, we will know the concept of the whole nephron. So how the fluids are filtering, and at which point what are the inorganic salts or organic products are filtered. So how it is filtering? This glomerulus have three filtration barriers. If you see here, this is first filter, and this will be your second filter, and this will be your, so first filter, second filter, and third filter. So what will happen from here? Blood will go, and here all constituents will get inorganic salts and everything will get filtered, and water fluids will get filtered from here, and it will go inside. So we are zooming into this area, and for this area you will be having three filters. So in this filtration, the first one will be glomerulus endothelial cells. In this cells will be having a pore size of 0.07 to 0.1 micrometers. Okay, and this will permit water plus all the solutes, but not the blood cells and platelets. And next one is basal lamellae. As the matrix is negatively charged, so it will prevent negatively charged plasma proteins. And this podocytes, these are the podocytes. So these podocytes, they will become like finger like structures, and they will encircles this one. So this podocytes, this will filter water, glucose, amino acids, very small plasma proteins, urea and ions. Okay, so if it is filtering everything, this will be the last products: water, glucose, amino acids, and very small minute, which will be below, smaller than 0.0062 to 0.007 micrometer. So if the plasma proteins are very smaller than this pore size, then only they will come out of this, and urea and ions. Let's come back to our nephron. So here what is happening, to know this filter, we have to know about one more part, which is vasa recta. Okay, so this is a blood vessel which is rotating our whole nephron. So from proximal tubule to distal convoluted tubule, it will be like surrounding our whole nephron. So how this urine is filtered? It is filtered with three mechanisms. Okay, one is glomerular filtration, and second one will be tubular reabsorption, and third one will be tubular secretion. Okay, so let's see what is glomerular filtration, tubular reabsorption, and tubular secretion. When it comes to glomerular filtration, we have seen we will be having a blood vessel here. It will be filtering, and that filtrate will go into our Bowman's capsule. Till that stage, it is called as glomerular filtration. We know how this glomerulus is filtering with the help of all the three membranes. Let's see tubular reabsorption. In this tubular reabsorption, there will be movement of water and solutes from tubules to circulation. Now our tubules are filled with more water, more solutes. Okay, that will again go into, I told you, you will be having vasa recta, right? So this is proximal convoluted tubule. From here, it will reabsorb. It will take again, this vasa recta will take this one again. So these are called as peritubular capillaries. Okay. So this solutes will go again into this peritubular capillaries. So next one is secretion. This peritubular capillaries, not only they will take, but they will give also. Again, some amount will be again resent back, like into this tubules, from circulation to again tubules. Okay, that's why it's tubular secretion. As these tubules are giving back to circulation, it's called as tubular reabsorption. That means peritubular capillaries are taking it again back. That's why it is called as tubular reabsorption. So what and all they are reabsorbing and what and all they are secreting. So first one, let's see proximal convoluted tubule. The reabsorption will be sodium, chloride, potassium, glucose, amino acid, urea and water. And if it comes to secretion, it will secrete creatinine, drugs. So it will secrete creatinine, drugs and hydrogen ions. So this is where our drugs mostly will get eliminated. Okay, in proximal convoluted tubule, they will go and they will get eliminated. So next one is descending loop of henle. Here we have only one reabsorption, that is water. There won't be any secretion in this descending loop of henle. There will be only reabsorption. And ascending loop of henle, here reabsorptions will be sodium, chloride and potassium. When it comes to secretion, you won't have any secretion here. And distal convoluted tubule, sodium, chloride, potassium, calcium, magnesium and HCO3, that is bicarbonate. And when it comes to secretions, hydrogen and potassium is secreted back. Okay, and collecting duct. In this collecting duct, there won't be any secretion. It will be only reabsorption, that is sodium, chloride, urea and H2O. Remaining water it will send back. You won't have any secretion. Okay. So this is reabsorption and this is secretion. So let's get into each and every part. So let's see proximal convoluted tubule. We will see how it is reabsorbing and how it is secreting. This is proximal convoluted tubule and this is peritubular capillaries. Okay. So in this proximal convoluted tubule, you will be having two parts. One is lumen and the other one is cell. So in this lumen, you will be having sodium ions. So this sodium ions from lumen, it will go into cell. Okay. And when they are going, they will, and here sodium is electrogenic. So while it is going into lumen, it will also transport glucose and amino acids. So it is taking glucose, and from here this glucose will enter into peritubular capillaries. And again sodium won't stop. So sodium again it will go in from lumen, it will go into cell. The sodium from lumen will enter into the cell, and from here it will go into our peritubular capillaries. So when sodium enters into this peritubular capillaries, hydrogen in this peritubular capillaries will come into the cell. Okay, now hydrogen came into the cell, and with the help of this antipode of sodium and hydrogen, you will be having one antipode which is called as sodium hydrogen antipode. Okay, with the help of that, again hydrogen from this cell will come into lumen. Okay, and here this hydrogen will bind with bicarbonates, react with bicarbonates, it will give rise to carbonic acid H2CO3. And this carbonic acid, which is again reversible with the help of carbonic anhydrase enzyme, it is converted into water plus CO2. So this CO2, again some of this CO2 will be in, it is transferred from lumen to cell and from here to here, and again it is reversed to cell and it will again come into our lumen. So this water and carbon dioxide, they won't be in proper position, they will be moving here and there. Carbon dioxide is acidic in nature, so this reaction here also you will be having bicarbonates, here also the same reaction will be there. Okay, so when sodium is coming here, you will be having potassium in this peritubular capillaries, right? That potassium will come back to our cell with the help of sodium potassium pump. Okay, this is our sodium and potassium pump. Okay, so once again let's see this one clearly. So first what will happen, this is our proximal convoluted tubule and this is our peritubular capillaries. In this proximal convoluted tubule, you will be having sodium. This sodium from lumen, it will go into cell, and as this is electrogenic, it will take one more compound with this one. So it will take our glucose and amino acids from lumen to our cell, and from this one it will go back to peritubular capillary. So now our glucose came back into our body again, even amino acids plus amino acids. Okay, again the remaining sodium will come into the cell and from there it is transported to our peritubular capillaries. When it is transporting to the peritubular capillaries, what will happen, the hydrogen which is in this peritubular capillaries will go back to our proximal convoluted tubule. In that proximal convoluted tubule, it will go into this cell. In this cell, this hydrogen will combine with bicarbonates, okay, and it will give rise to our carbonic acid. And this carbonic acid, with the help of enzyme which is called as carbonic anhydrase, it is converted into, it is breakdown into water and carbon dioxide. Okay, the same hydrogen, it will be equally distributed. This hydrogen is equally distributed into lumen and cell. So the remaining amount of lumen, it will combine with the carbonates which are in lumen also, and it will give the same result. Same cycle is repeated. And this water and carbon dioxide which is in lumen and which is in cell, it will send it to our peritubular capillaries, and this will be to and fro motions. It will go back to tubular capillaries and it will come back to proximal convoluted tubule. It is like continuous process. So this is our proximal convoluted tubule. So next, let's see ascending loop of Henle. In descending loop of Henle, we have seen there is only one reabsorption, that is water. So no need of that one. So let's see the other one, which is ascending loop of Henle. So let's see the ascending loop of Henle. In this ascending loop of Henle, you will have lumen, cell, peritubular capillaries. So here in lumen, you will be having potassium, 2 chloride and sodium. Okay, so you have a co-transporter called as sodium, potassium and chloride co-transporter. So what will happen due to this transporter, when this potassium will travel from lumen to cell, and at the same time this chloride and sodium, all this will travel at a time to the cell. So here potassium came into this cell and chloride came into this cell and again sodium. And this sodium, it will travel to peritubular capillaries, and this potassium also travel to peritubular capillaries. Here instead of two chloride, only one chloride will travel there. So when sodium enters here, we have potassium. Potassium doesn't like sodium, so it will return back. So potassium will return back to lumen. It will return back to lumen. Okay. So what is happening in this? You have a co-transporter which is called as sodium potassium chloride co-transporter, and you have three ions which are potassium, two chlorides and sodium. Okay. So due to this transport, these potassium chloride and sodium will combinedly travel to cell, and from cell they will travel to peritubular capillaries. But we have sodium, right? So when there is sodium, potassium won't be there. So instead this potassium will come back to our tubules, come back to our lumen in the tubules. Okay, descending loop of henle. Okay, so next let's see distal convoluted tubule. So if you see this distal convoluted tubule, you will be having, so this is distal convoluted tubule and this is peritubular capillaries. So if you see in this is lumen and cell. So here in distal convoluted tubule, you will be having sodium. Okay, sodium is passed into our cell, and from cell it is going into peritubular capillaries. So when we already know that sodium and potassium are enemies, so with the help of ATPase pump, this potassium will come from peritubular capillaries to cell, into the cell, and from cell it will go into lumen, and you will be having chloride. So this is chloride. You will be having one transporter through which chloride will go into peritubular capillaries. Okay, here one more thing, you will be having special category which is magnesium and calcium. Here we have magnesium and calcium, in which this magnesium and calcium, they will transfer in between the cells. Okay, through junction methods. So here what will happen? First, sodium will be there. Sodium from distal convoluted tubule lumen, it will go into cell, and from cell it will go into peritubular capillaries. Okay, and when it comes to potassium, we know already sodium is the enemy of potassium. So when sodium enters into peritubular capillaries, from there potassium will go into distal convoluted tubule. Okay, in that it will go into cell, and from cell it will go into lumen. Okay, with the help of sodium potassium ATPase pump. So this is sodium potassium ATPase pump. Through transport, this chloride will also go from lumen to cell, and from cell to peritubular capillaries. Okay, and we have one more thing. There will be a transport of magnesium and calcium from cell to cell, between the cell to cell. So this is distal convoluted tubule. Next one, let's see distal convoluted tubule plus collecting duct. Okay, this is the place where we have this distal convoluted tubule and collecting duct. Okay, this area. Okay, this is comes under both. So it will come distal convoluted tubule as well as collecting duct. Okay, this area we are talking about now. So here the first one will be, this is peritubular capillaries, and this is collecting duct and distal convoluted tubule. So if you see here, this will be lumen and this will be cell. Okay. Sodium is coming from here, from lumen to cell, and from cell it is going into peritubular capillaries. If you have remembered the proximal convoluted tubule, in that sodium is dependent on this hydrogen, isn't it? So when sodium is going, hydrogen will also go with sodium. It will have the same method. Okay. So this is the whole process, and here Cl will go into cell of the distal convoluted tubule and connecting duct, and you will be having another one which is sodium again, but here we will be having another mechanism, that is aldosterone. You will be having aldosterone port here. Here you will be having sodium in distal convoluted tubule and collecting duct, that will go into cell of the CD and DCT, and from there it will go into TTC. Okay. Actually, here this depends on the aldosterone. If the aldosterone is stimulated and it is increasing, then the sodium reabsorption will be more. Reabsorption means from distal convoluted tubule to capillaries. So that will increase. And we all know potassium will come back. This doesn't show any effect on potassium when it is increasing, but it will increase sodium transport from tubules to capillaries. Okay, reabsorption will increase. Sometimes we know that sodium and potassium are enemies. So when sodium levels are increasing in capillaries, the potassium which this capillaries have will be transferred into these tubules. So some condition this will increase potassium also. But here this sodium transport depends on our aldosterone. So this is aldosterone port. Okay, this is which is hormone. So last and final, collecting duct. So here also you will be having peritubular capillaries this side, and you will be having collecting duct here, and this is collecting duct, peritubular capillaries. So in this collecting duct there will be one, the only water is reabsorbed from the tubule. So how? This is called as aquaporin. So these are aquaporins. So what is the function of aquaporins, and who controls aquaporin? Our hormone called as ADH. Okay, this will control aquaporin. ADH means anti-diuretic hormone. So what will happen if we are less than water from morning to evening? If I am not taking any water, we have to store water, right? So you will be having, in collecting duct, you will be having more water. So this aquaporin will get opened. This antidiuretic hormone will activate this aquaporins. This aquaporins will transfer water into peritubular capillaries. So water is reabsorbed into our capillaries. Okay, so that we won't lose so much of water from our body. This is the end step for our urine collection, urine formation. Okay, so after this, the remaining water which is in this collecting duct will go as a urine. So this collecting duct is having water. So this antidiuretic hormone, what it will do? It will open this aquaporins. So after this, you are left with urine. Okay, this urine consists of, till now we have seen water, H2O, plus some waste like carbon dioxide, ions like sodium, potassium, okay, and some metabolites. So now let's get into our diuretics. So now let's see the definition of free water clearance. What is free water clearance? It is defined as the volume of urine excreted per unit time. Per unit time in excess of that required to excrete the contained solute isoosmotically with plasma. That means urine doesn't only contains water, right? It also consists of some solutes. So when there is only excretion of urine without any solutes per unit time, there won't be any solutes, okay, and you will be having only urine. So think this is your nephron, okay. Here a descending loop of henle, this will only reabsorb water, isn't it? When it is reabsorbing only water, what will happen? Here the solution become hypertonic, okay. When it is becoming hypertonic, means there won't be any much water here, there will be only solutes. And at which time this is excreting all this water without any solutes, that is known as free water clearance. So this free water clearance is divided again into two types. One is positive free water clearance and negative free water clearance. So what is positive free water clearance is when the urine is more concentrated, then it is negative free water clearance. When the water is more diluted, then it is known as positive water clearance. We have another classification which is isotonic. That means you have equal amounts of solutes and water. And next one comes to organic ion transport. In proximal this will be happen mostly in proximal convoluted tubule only. So in proximal convoluted tubule, they will be bidirectional. It won't be like it should only reabsorb or it should only secrete. This is the reason most of the drugs act on proximal convoluted tubule only. I will say one example. So actually uric acid used to secrete more when than reabsorption. But when I am giving penicillin, the reabsorption of uric acid will be more than its secretion. So depending upon that organic acid or organic basis, it will be bidirectional active transport mechanism. So it can reabsorb or it can secrete depending upon that acids or base. So let's get into the drugs. So what are diuretics? So if you see this diuretics, these are the drugs which causes more loss of sodium and water in the urine. If we are using this diuretics for longer period of time, defensive mechanism in our body, what it will do, it will restore this sodium. For example, if the person have any heart diseases, so he have to use this diuretics like every day, okay, because of his edema or because of his blood pressure, he have to use this diuretics daily. When he is using this diuretics daily, after certain time his body will show a defensive mechanism, that is there will be loss of water but there won't be any loss of sodium. So sodium is retained again, the sodium levels will be normal again. So if you think that if we take more diuretics there will be loss of sodium, yes, there will be loss of sodium but not drastic loss. So let's get into the classification. So this is our classification. In this you have high ceiling diuretics and next one is medium efficacy and third one is weak diuretics. So let's get into the high ceiling diuretics. This is the best drug in all diuretic drugs, that is furosemide. Next one is bumetanide, torsemide. And when it comes to medium efficacy, you will be having benzothiazide and you will be having another subclassifications thiazide like. So when it comes to benzothiazines, the drugs are hydrochlorothiazide and hydroflumethiazide, okay, and benzothiazide. When it comes to thiazide like, the first drug will be chlorothiazidone and zipamide, indipamide. And when it comes to weak diuretics, the subclassifications are carbonic anhydrase inhibitors and the drug is acetazolamide. And when it comes to the another subclassification is potassium sparing diuretics. Subclassification in this potassium sparing diuretics are aldosterone antagonist and renal epithelial sodium channel inhibitors. So in aldosterone antagonist, the drug is spironolactone. And when it comes to renal epithelial sodium channel inhibitors are amiloride. And the next subclassification of this weak diuretics are osmotic diuretics. And the drugs under these osmotic diuretics are mannitol and glycerol.